Hi everyone, in our video, we will address medication administration errors. This group project will include Simin, who will identify problems. Mikaela and Zahra will talk about diagnostics. Fatemeh will talk interventions. Jacob will discuss simplex and implementations. And Amber will talk spread and sustaining improvements. And the issue appeared in the video. Learning from error is intrathecal injection error, which is a drug intended for use intravenously is mistakenly given into the spine. The patient then may experience paralysis and even death. The relevant National Safety Quality Health Service standard that applies to this issue is medication safety. Medication errors cannot be eliminated, so we aim to reduce the percentage of medication administration errors within 6 months trial period by implementing vast using 8 rights use and relevant documentation on the supervision and audit. Health professionals, including nurses, doctors, other specialists, hospital management departments, including NUMS and ANUMS, alien health staff, educators in hospitals and education institutions, and audit should involve in this project.
A medication error can be defined as a preventable incident that results in the medication not having the desired effect, which may cause harm to the individual. The issue of medication errors is still prevalent in Australia. According to the National Safety and Quality Health Service Standards 2nd edition, in the year of 2011-2012, there were 230 hospital admissions related to medication incidents. Close to half of these incidents are avoidable. This alone cost $1.2 billion. In the video, Learning from Error provides a specific example of the detrimental effects that medication errors can have on a patient's life. Mrs. Jane Hughes was scheduled to have 2 procedures completed in one day, an IV and intrathecal injection. Unfortunately, due to poor management, she was given her IV injection vincristine intrathecally, when instead it should have been administered intravenously. In almost all cases, the individual passes away. One of the reasons the medication error occurred in Mrs. Hughes' case was because the nurse and the doctor were interrupted by a medical emergency. The nurse, who was experienced in both the procedure and was familiar with Mrs. Hughes, left to help. The doctor, who was under a lot of stress, chose to complete the procedure with the help of another doctor who had just come off a 12-hour shift and was tired. In an Australian study that was conducted by Johnson et al., which focuses on identifying and recording interruptions while nurses are on medication rounds in an acute setting, 99% of the medication events were interrupted. 73.3% of the interruptions happened during the medication preparation, and in 40% of the cases, interruptions were caused by other nurses. 34% of these cases, a procedural failure took place as a result of the interruption. Interruptions affect patient safety, so it is integral for them to be addressed.
Nurses are faced with distractions and interruptions for many reasons. These inevitably result in unsafe practice and risk to patient safety. Some strategies to reduce medication errors include developing visual cues to alert others that medication is being administered. These cues include quiet zones as well as coloured lanyards or vests, making it really obvious that the individual should not be interrupted. Therefore, this will reduce confusion as all staff will be educated on the policy and will understand the importance to stay away and not interrupt people in these areas or wearing these items. Other interventions that will assist in generating improvement include checklists that encompass key points about all 8 rights of medication administration. Before the medication is administered to the patient, each right will be documented and ticked off, thus allowing all sections to be covered and therefore nothing will be missed. This strategy will reduce human errors such as absent-mindedness, as well as being a thorough tool for administering medication in order to decrease errors. It also gives a guide to what component of the procedure that a nurse is up to prior to being interrupted by another team member. In conjunction to this, individuals should always research a medication if they are unsure of what its intended action and potential adverse effects are. Therefore, they will be educated and then they can educate the patient. To measure whether the new policy or strategy is effective, facilities should create SMART goals, specific, measurable, achievable, relevant, and timely, to develop a holistic understanding about the progress of a goal. This strategy is potentially effective because it can be utilized throughout an entire facility.
There are two changes that we want to test in this section. The first one is particular ways that health professionals are going to wear during medication preparation and administration, and the second test is the use of 8 RISE checklist. Aim of these two tests is to measure if any of these changes can minimize medication errors. So who is involved in the test? All health professionals, including nurses, doctors, nurse in charge, nurse unit manager, are involved in this test. These two interventions are going to be tested into randomized wards. Staff must be aware of the purpose of the study design, and the whole process, and consent must be obtained from volunteer staff. The study design is called before and after design, where data is collected before and after the change. For the first test, baseline data can be collected by conducting a survey before the test and comparing the result with the result of another survey that is going to be conducted after the change. For the second test, we need to use hospitals' previous records regarding medication errors and compare it with the rate of medication error after the change. In order to get a more reliable data, we can use anonymous report forms, which health staff can fill when medication errors happens, and at the end we compare data before and after the change to see if any of these interventions have been effective in reducing medication errors.
So I'm going to be talking about the impact and implementation of our system. So we're going to use a systematic monitoring model to make sure that all data is recorded the same way through the entire health system. So we're going to use a risk-man system. So this system should already be used by staff. So they should be very good at using it, which will make for reliable data. Reliable data is useful data. So our goal here is 20% reduction in combined number of medication errors and near misses in a 6-month period. So these are things that should already be recorded within the risk-man system, which means we should have good pre-existing data that's very reliable. That allows us to then compare it to our data 6 months down the track when we've finished the trial. So this goal, of course, can be reassessed in the future. The secondary in-house goal is maintaining staff compliance of above 90% as a bare minimum, so that should be promoted by the relevant heads of body and the NUMs and ANUMs, people like that, to encourage their staff to be very compliant. So we're going to conduct this through audits. They're not quite as reliable as the risk management system, obviously, because you can't be auditing all the time. You can never audit 100% accurately, but this still should be a good system to be able to get very close to accurate data on how well the staff are complying. We're also going to be conducting surveys to understand what the staff think of this intervention. So we're going to assess the success of the intervention based on also whether staff are able to work with it and think it's a good idea. And then that allows us to make sure it's successful going into the future. So I'm going to hand you on to Amber now to talk more about the rest of our assignment.
The spread of the improvement and sustaining the improvement of our interventions is so important to the patient's safety. So firstly, I want to talk about the continuous education that should be provided to healthcare professionals who are involved in the administration of medications. So talking about what they need to know and how they can be giving the medication in the safest way possible should be given to all healthcare professionals that have interactions with the patients and their medications so that they know what needs to be done. So then specifically for our interventions, healthcare professionals should be constantly updated with the results of their interventions. So they're seeing where they're doing well, yes, they should keep doing this, and also where areas are lacking, and they can consciously make an effort to change that. So then specifically I want to talk about the documentation. The documentation is so important to the spread of and sustaining the improvement, basically because it allows the interventions to be monitored constantly and then documented constantly to see any changes or progress that's being made. So goals and targets can be met, but also allows for flaws to be identified early. As a result, interventions can be changed or new ones can be added. So that ties into the future planning of it. Future planning, we can look at our documentation and go, this intervention is working really, really well. We want to start implementing this into different wards in the hospital so that we can improve the patient safety for everyone. But then we also look back on our documentation and think, this area isn't working so well, this intervention isn't working so well, something has to change, what can we start adding what can we change to improve the patient safety. So we want to always be constantly thinking, how can we make improvements to the system?